Hi, and welcome to yet another episode of the Vet Dental Show. Today, we're going to feature Dr. Mark Epstein. Dr. Mark Epstein is a specialist in pain management and one of the best speakers, if not the best speaker in the world, and one of the most knowledgeable, if not the most knowledgeable, in pain management. And he has, in the very recent past, done a course for us on pain management, and this is a segment out of that course. And if you are enjoying this episode and would like the entire course, I'll give you that information at the end of the show. Right now, enjoy Dr. Mark Epstein.
Let's talk about ketamine. Ketamine, the commercial products that we use, is a racemic mixture of two enantiomers, the R-ketamine and the S-ketamine. It is the R-ketamine responsible for all the psychotropic effects and hallucinatory effects, not all, but almost all. And S-ketamine is very sparing of that and is really where the analgesic effect, pain-modifying effects come in. Now, there is a commercial S-ketamine product that's used on the human side, but the ones that we use is going to be a mixture of these two. Now, here's the trick. We know it as a NMDA receptor antagonist. Recall that the NMDA receptor is a big sodium and calcium channel, and yet it has a magnesium plug that sits right in the middle of the channel. And only by sustained or massive binding of excitatory neurotransmitters like glutamate will that magnesium plug kick out, which opens it up. But when you look at the calcium channel, we want to then try to block it. Here's the catch. The NMDA receptor, here's a magnesium plug. The binding site for the ketamine is very deep inside the channel. And so what that means is that in order for ketamine to get into the channel here, the magnesium plug is already out, the channel is already open, calcium has already come in along with sodium, this neuron is already depolarized and transmitting nociceptive impulses, processing pain up to the brain. If that's the case, then can we really consider ketamine to be a genuinely analgesic drug? Analgesic drug. And the answer is not really. The terms that are used with all of the data that we have in various models and clinically on the human side is that it's not analgesic exactly, but we can say that it is, yes, pain preventive. It is anti-hyperalgesic. It keeps pain from being any worse than it is supposed to be. That is, that it keeps the exaggerated component of pain, which is part of that NMDA sensitization mediated hypersensitization. It is opioid-sparing. It decreases persistent post-surgical pain even well after the ketamine has been withdrawn, and is quite safe. This is a consensus statement that has, or consensus guidelines on the human side, and these are the conclusions that are drawn from many studies that are multiple, many of them actually are multiple systematic reviews. So the evidence is really clear about this on the human side. Now, if you want to use the term analgesic, that ketamine is analgesic, fine. I don't get too pedantic about this. I get pedantic about other things, but technically it would not be pain, it'd not be analgesic, but we can say pain modifying, anti-hyperalgesic, anti-sensitization, those kinds of terms. And what data do we have about efficacy and safety on the canine and feline side? Obviously, we're not going to have the kind of robust studies and systematic reviews and meta-analyses that are found in people. What we do have are a number of individual studies, and really all of them do in fact point to a benefit. And it's essentially consistent what is found on the human side, rodent models, and elsewhere. Nothing really contradicts those findings. From safety, it's been used in various capacities in different kinds of models. Keep in mind that ketamine was developed in the early 60s for battlefield use in Vietnam, and it preserves the sympathetic nervous system. And you can imagine if it's safe for those soldiers and Marines on a jungle floor, that we can find it safe in a variety of clinical circumstances in the veterinary setting as well. On the human side, it's been long understood of the benefits of ketamine. The problem has been that there was no consensus until this document here on dosing, frequency, duration, kinds of patients, and clinical circumstances, and so on. So these guidelines attempted to put that together and put it in a box, if you will, so that on the human side of the perioperative domain, for acute pain, that there were ways to flesh out the kind of the highest, best, and wisest use on the human side. And you would be not surprised to know that of the several populations of patients that might kind of correlate to veterinary patients, it's patients that are going to be in more severe pain. That is, they come in with a lot of pain, or they are going to undergo a pretty severe or big surgery. And that's where ketamine finds its highest and wisest use. Now, it can also be opioid sparing. That applies to us now these days. There are areas in the human side where it does not apply. So humans or people that are opioid dependent, opioid tolerant, if they have abuse issues with opioids, then we don't have those patients, obviously, on the veterinary side. In terms of the dosing ranges, there's a loading dose here, and you'll be not surprised to know that this is actually very similar, almost exactly what we use in veterinary medicine, because it was modeled after the experience in humans, as are the CRI dosing themselves. I'll go over that in just a minute in dogs and cats. And in terms of safety or contraindications, really none, not really. You can make the case that you shouldn't use it in uncontrolled cardiovascular disease. In people, that's mostly folks that have had a heart attack. But even in those people, we're talking about sub-anesthetic doses of ketamine, but might even be okay in them. When it comes down to it, very safe, and the patient populations that we would find in humans are applicable to veterinarians as well. So is ketamine an analgesic? Not technically, but yes, we can say it if we want to describe it that way. But does it prevent pain? Is it anti-hyperalgesic? Is it anti-hypersensitization? Is it pain-preventive? And so on. The answer is yes, it is. Is it safe? I've shared the data with you, and the answer is both in humans and in multiple animal species, including dogs and cats. That answer is going to be yes, it is. So how do you do it? We don't like to get too formulaic in veterinary medicine, to Betty Crocker, but there are times and places for it. This may be one. So the way you do it is you're going to put this in a bag. Basically, it's 0.6 mLs of the 100 milligram per ml solution into a liter. So 60 milligrams into a liter. And you're going to be giving that at a surgical rate. And formerly, those guidelines were at 10 mils per kg per hour. Now they are at 5 mils per kg per hour. However, if you have a lot of blood loss or insensible loss and you need to turn the fluid rate up, you may up to 10 ml per kg per hour, basically doubling it, and you will still be within the range and the target range to achieve plasma levels that we wish for sub-anesthetic ketamine CRI, which are very low, by the way, very low. And then after surgery, you turn it down to your maintenance rate. We ought to start off with a loading dose. Now, the idea here is that we are going to push the plasma levels fairly high, and these are approaching kind of anesthetic levels, and then the CRI will hold it on a basal level. I do not know if you were to just start the CRI without the loading dose, if it's going to be sufficient or how long it would take to achieve proper plasma levels, etc. So all the protocols do describe for loading dose, and I'll tell you how to achieve those in just a second. You will also ask me, how long do I keep them on this maintenance rate? I'm going to tell you that we really don't know. There's no consensus on the veterinary side for sure for how long to do that. In my own practice, we basically have these patients on fluids, and ketamine is in the bag for as long as they would ordinarily be on fluids. We don't necessarily try to keep them on fluids just so they get the ketamine CRI. So whether it's just during surgery or whether it's for a few hours after surgery or whether it's 24 hours overnight, they're going to get the ketamine CRI in their fluids. So how do you achieve that loading dose? Multiple different ways to do it. You could just go ahead and give ketamine as a loading dose. That was very similar to the dosing on the human guidelines that I showed you. But this is nearly anesthetic, and so it's going to be way anesthetic reducing. So your induction agent, whatever it is, can be lowered significantly, probably as much as half. You could also just mix the ketamine with propofol, your induction agent, and now has the vernacular term ketofol, which is described in the literature, now becomes your induction agent, just happens to have ketamine in it, but it's, again, probably half the dose or even less of propofol induction, because that can be up to 4 mg per kg. So it can be much less than that, as long as ketamine is in that syringe with. If you use ketamine and Valium or Ket-Val as an induction agent, that will do it. If you use Tilazol, which is tilletamine as diazepam, that will do it. I assume that tilletamine has the same exact kind of neuropharmacology as the ketamine does. And if you use DKT, dexmedetomidine, and ketamine and torbugesic as a intramuscular pre-med, that will do it. So however you choose to do it, there's your loading dose. In veterinary medicine, we have guidelines on the patient populations that this should be deployed. This statement here comes from the AHA AFP Pain Management Guidelines, but they mirror comments made in the Global Pain Council from the World Small Animal Veterinary Association and IVAPM as well. That basically, if it's a patient that is prone to maladaptive pain, that you can predict it or you think it's already in it, then ketamine should be deployed for those patients. Sub-anesthetic ketamine should be deployed as a CRI for those patients. What are those patients? And our guidelines flush it out a little bit more. It doesn't say just those that might be in severe pain post-op, but these are the ones that are most likely to have more severe pain post-op if they have pre-existing inflammation. Examples: old dog with osteoarthritis. You're going into doing some oral surgery with bad periodontal disease. You get the idea. Major trauma. Maybe these patients came in with trauma, hit by car, big dog, little dog. Get the idea. Maybe they didn't come in with that kind of trauma, but you're creating the trauma. So it's a nice quiet sarcoma, a mast cell tumor, and you just have to do a wide resection. You're the one creating the trauma. Perhaps it's nerve injury. And perhaps the patient came in with nerve injury as part of trauma, or maybe it has intervertebral disc and you're having to do some kind of lumpectomy somewhere else on the body, or you're doing an amputation. And then any chronic pain syndrome, no matter what the source of it, because essentially the central and the peripheral nervous system is already wound up, so to speak. There's already sensitization present. So all of these things predispose to maladaptive pain. Some of these patients might already be in it or have an element of neuropathic pain, a neuropathic pain component. This is where you will want to use sub-anesthetic ketamine CRI. And keep in mind, once again, from the safety side, this is sub-anesthetic, way sub-anesthetic. As a matter of fact, if you were to have a small dog and you had that kind of concentration of ketamine in those fluids, and somehow that bag ran into a small dog or a cat, you are going to have more problems with fluid overload than you're going to have with the ketamine. That's my view. And I think one of the questions in the last Q&A was about patients waking up kind of psychotropic or having delirium when ketamine has been used. But I'm here to report that I doubt that's what's causing those kinds of rough recoveries, not at these kinds of doses and rates. Ketamine is one of these molecules that the more it's looked at, the more fascinating it becomes. And it turns out that patients that were receiving kind of ketamine infusions for chronic pain also had clinical depression lifted. And now we have a new product, a therapeutic that's the first new therapeutic class of drug for severe clinical depression in the last 30 years, essentially since the SNRIs came out. It is a nasal spray. It is S-ketamine, and it's used in the human setting where people have to sit in the office for a little bit just to make sure there's no adverse effect. And it's a fascinating area of study. And essentially, as I've mentioned, clinical depression and chronic pain or maladaptive pain, they are all sharing the same pathways, the same neurons, the same receptors like NMDA receptors, the same neurotransmitters, and so on. Ketamine may also help with glial dysregulation, which may help with some of the opioid dysregulation, like dependence and tolerance, but also opioid-induced hyperalgesia, and so on and so forth. With that in mind, it just goes to show you that life really does begin at 60, I'm pleased to report. Ketamine has been used for many years to treat chronic pain as well, but once again, there was no set protocol and no one knew exactly how to use it, or what doses, for how long, or how frequently, and for what kinds of conditions, what kinds of chronic pain. So this particular paper came out also just a couple of years ago and designed to try to lend some clarity to that on the human side. So you can see the kind of patient populations that it has found benefit in, but the protocols never were really, there was never a consensus developed on the kind of protocols. Once again, contraindications, you can hypothesize some, but in practical application, it doesn't seem to be a serious problem. I do want to point out that in these ketamine infusions, not all of them were sub-anesthetic. In some of them, they were given quite high doses to the extent that people were actually given Valium, so they went into ketamine comas for several hours, and that was part of the protocol. So you can imagine that for some patients that had unstable cardiovascular disease and other CNS issues, liver disease, that there might be a problem with those kinds of doses. And so this is basically the conclusion of that paper. And I think that we're going to find more and more coming out on the human side about, again, the highest and wisest and safest use in the chronic pain setting. And when it comes to the veterinary side, obviously we have even less information about that for dogs and cats. It's been used anecdotally, but there are studies now being either designed or underway. These are pilot studies, but you can see the protocols here are pretty variable as well. This is giving sub-anesthetic ketamine CRI overnight for 24 hours. This is giving it for a few hours, several days sequentially. And this is using it as a sub-Q injection device for 24 hours sub-Q. So I don't know the outcomes here of these studies, but I do have a lot of anecdotal reports and colleagues that use them fairly regularly. I think this is going to be an exciting and emerging area of practice. And if you choose to use ketamine for chronic pain conditions, you're certainly not out of bounds, and you're probably actually in pretty good company for doing it.
I trust you enjoyed that segment that Dr. Epstein provided for us today. If you're interested in registering for that entire online course, yours forever, 24/7, go to the link ivdi.org/pain and use the promo code PAIN. You'll get access to that and can download it and listen to it immediately. Hope you had a great week. Hope you have a wonderful week coming up, and we'll see you next week. Take care.